haven't gone through a period yet where we have a relatively high vaccination rate and yet a high rate of transmission, which is translating into a high number of hospitalizations from COVID-19. Some of this is driven by the 5 to 11-year-olds in school who are just starting to get vaccinated. And by the way, the public health field and healthcare field across the state have vaccinated 13,000 5 to 11-year-olds since the vaccine became available late last week. So that is just tremendous. But you know, our kids are in school, which always drives diseases. COVID's being driven by weather cooling down and the natural increase in respiratory illness as people start to spend time indoors. We didn't have Delta last fall, and we all know that's magnitudes higher in terms of its level of contagiousness. And then people are back to normal activities and they're needing hospital beds for things like trauma or delayed surgeries or other reasons. So it's really a unique point in time. And today we want to discuss with you some of the strategies to address this. And we'll start with Governor Polis, who's going to join us today. If he's not on yet, then I do want Dr. Rachel Herlihy, state epidemiologist, to talk about where we are in the pandemic, and also Dr. France to share some of that time to talk to you about Colorado's guidance on booster shots and also crisis standards of care. So let me pause and just see if the governor is with us yet. Okay, then why don't we start with Dr. Herlihy?
Okay, great, thank you. I'll bring up my slides. All right. Jill, can you verify that you can see my slides?
Yes, Rachel.
Okay, great. All right. So I want to start here with just a quick update on the stats. So this figure is showing, this table is showing you a comparison of the numbers in August when we last met to the numbers now. So not surprisingly, we've seen an increase in cases, hospitalizations, deaths that have occurred in the state. The number of outbreaks have also increased. But we're in a very different situation now than we were in August, in that our percent positivity is much higher, our case rate is overall much higher, and that is much of the data that I'll be sharing with you today. While we were seeing a predominance of Delta over 98% back in August, we're now consistently seeing 100% Delta. I get questions almost on a daily basis about whether we're seeing some sort of a new variant in the state that is driving transmission right now, and that is not the case. At this point, virtually everything we are seeing in the state is the Delta variant, and we really have not seen another variant be able to get a foothold here in the state or in the US in general. All right, so I wanted to start here with an overview of key trends in the state. So I'm going to walk through each of these bullet points with you, and then I will proceed to show you data supporting each of these findings right now as far as our key trends in the state. So COVID-19 cases, percent positivity, hospitalizations, and deaths have been increasing in Colorado since August. The Delta variant dominates, as I mentioned. Case rates and percent positivity are currently highest among school-aged children. And that is specifically the children that are 11 years of age and younger. And I'll be showing some of that data to you as well. So that's the population that has only recently become eligible for vaccination down to age 5. The majority of hospitalizations and deaths are occurring among unvaccinated adults. That stat has typically been around 80% for the last few weeks. Vaccine effectiveness against hospitalization and death remains high. We are seeing more waning immunity associated with infections in general, but much less with hospitalization and death. There are perhaps some exceptions, though, for older Coloradans, and we are seeing some limited evidence of waning immunity among older Coloradans when it comes to hospitalization data and deaths as well. And again, I think this really reinforces the need for booster doses, really in all Coloradans, but especially that older population that is most susceptible to severe disease. And I know we'll be talking more about booster doses as the meeting goes on. Modeling projections that were updated just yesterday following a rapid increase in hospitalizations that's been noted really in just the last couple of days is now showing that COVID-19 hospital demand will increase until late December and could potentially exceed our current hospital capacity. I'll be showing you an updated modeling slide that shows some of those projections and want to spend some time talking about that in a minute. In addition to non-pharmaceutical interventions, booster vaccination and monoclonal antibody treatment can decrease hospital demand, and I'll be showing you some modeling data that supports that. And then finally, outbreak and long-term care facilities have increased with this current wave of illness that we're experiencing, but involve fewer cases, hospitalizations, and deaths. And I think that is really due to several things: vaccination, testing efforts that are in place in those settings, as well as really critically important infection control practices. All right, so moving through the data. So this is the latest figure we have showing you case trends in the state. We have seen this steady increase in cases. You'll note that the steepness of this line about 2 weeks ago increased pretty substantially. So we did experience this pretty rapid increase in cases in the state, a little bit more of a slower increase in the last week or so. But again, I don't know if that means that we're getting anywhere close to a peak or stabilization in cases right now. Really, at this point, I believe we're going to continue to see an increase in cases for weeks to come. Trends by age group. So this is a figure that is showing you those case rates by age group. I mentioned at the beginning that the highest rates that we are seeing right now among our school-age children, particularly our school-age children, that until last week were not yet eligible to be vaccinated. I think this is, again, great data to support the importance of vaccinating our school-age children at this point to ensure that they have the protection that older children and adults have had for many months now. You'll see that after that 6 to 11-year-old population, we see the increased rate, or the highest rate is, second highest rate is in the 18+ population. And again, that is concerning, knowing that that adult population is the population that's most likely to be hospitalized or have cases result in death, followed by the 12 to 17-year-olds. And then our lowest rates continue to be among the 0 to 5-year-olds, our youngest population that does seem to be slightly less susceptible. So this is a figure that is just showing you the difference in trends that we're seeing in Colorado right now compared to the US. So for many months throughout the summer and into the early fall, Colorado's rates were much lower than the US rates overall. That has changed in the last 2 months or so, where we have seen this continued steady increase in cases in Colorado, while we've seen a steady decline in cases in the US. Notably, though, in the last week or so, we have seen that trend for the decline in US cases flatten out, and we're really seeing in many more states now an increase in cases occurring. So I'll show you some regional data, but in general, we are seeing that overall steady decline that we were seeing in the US overall seems to be flattening out, meaning that while Colorado rates are going up now, it could be that we are ahead of the curve perhaps, and we're going to see more states move in our same direction with increasing case rates as time goes on, as we move further into the fall. All right, so this is a figure that shows you Colorado's position as far as case rates ranked against other states across the country. So you'll see here that Colorado's case rates are certainly high, among the highest in the country right now. You'll see that states above us that have higher rates tend to be states that are to our north. So we are seeing some sort of a regional trend here. It's difficult to know, and Director Ryan mentioned this as well, if what we're seeing here is seasonality that's associated with characteristics inherent to the SARS-CoV-2 virus and the ability of the virus to spread when temperatures are lower or humidity is lower, or if this is really representing more of a change in human behavior and individuals moving indoors and risk of transmission increasing. But there does seem to be something here where we are seeing that especially northern central states, are states where we're seeing increased rates of transmission right now. And those increases that we saw several months ago in the southeast part of the country seem to be trending down. So we're seeing states in the southeast now with pretty steadily declining cases. All right, so moving within Colorado and looking at trends across the state, at this point, most counties in the state, you'll see, except for the exception of Lincoln County, have rates above 100 7-day cumulative incidents. And we do, week by week, continue to see more of our counties move into this orange level of disease transmission or this red level of disease transmission. I would say that hotspots in the state right now would be considered Mesa County to the west, Pueblo, El Paso, and some of the surrounding counties. We're starting to see a little bit of an increase once again in some of the San Luis Valley counties. Montezuma has had high rates for several weeks, but their rates are declining a little bit right now. But in general, rates are pretty high across the state, so pretty consistently seeing high rates of transmission, including here in the metro area. So this is just a series of epidemic curves that show you case rates and trends overall for Colorado's largest counties. So I'm going to walk through 2 slides here that show you just some of our largest counties and what the trends look like. There is, of course, as there has been throughout the pandemic, quite a bit of variability in trends that we see across the state. And I'm only going to show you our largest counties. But I do want to emphasize that trends can be different across the state and they're not universal across the state. But in general, most of the state is experiencing an increase, and you can see that in the upper left-hand corner here, the figure for Colorado overall. And then you can compare that trend in Colorado to different counties along the Front Range. And you'll see that in general, those counties are seeing increases. The rate of increase is a little bit variable from county to county, but in general, most of our counties are experiencing increases. And the next slide just shows you a few additional counties here. I do think it's important to point out that both Mesa County and Pueblo County here have seen these pretty rapid accelerations in cases in the last week or so, and have pretty high rates of transmission compared to many of our other large counties. All right, percent positivity. So this is the percentage of tests that come back positive, specifically PCR tests in the state that are coming back positive. This is a good leading indicator for us, and often a place where we see trends change sooner than they might change in case data or hospitalization data. So this is a measure that I follow closely to try and understand what the next couple of weeks of transmission might look like in the state. And we are seeing this steady increase in percent positivity, and a recent steep increase in percent positivity as well, now statewide at a value of 9.5%. And we are seeing much higher numbers come out of some of our community testing sites in certain parts of the state, well over 20% in some of those regions. All right, so I had mentioned at the beginning that we had several days of a really steep increase in the number of hospitalizations occurring in the state. And so this is a figure that shows you hospitalizations over time. You'll see this almost needle point here at the far right end of the figure that shows that really rapid increase that we've seen for the last 3 days or so. So a significant spike in the number of hospitalizations. And this is important to talk about because this is really the data that our modeling team is using to try and estimate or forecast what hospitalizations might look like in the state in the next couple of weeks. And so when we see a really rapid rise in the number of hospitalizations, the change of that curve, the change in the shape of that curve, meaning that curve is becoming steeper, that really changes the overall trajectory and the way that the data or the model fits to our data. And so because of that, we do see changes in projections. The number of hospitalizations change when we see significant increases like this. And I'll show you that data in just a second. But want to first emphasize the fact that we do continue to see the vast majority of our hospitalizations occurring among our unvaccinated population. And this has been consistent for many months now. At this point, we're seeing about 80% consistently of our hospitalized patients are unvaccinated individuals. As Director Bookman and others consistently say, we believe that this is really a pandemic of the unvaccinated. Another finding that we've had consistently for many months now in the state is this close correlation that we see between county level vaccination rates and county level hospitalization rates. So to walk you through this figure, on this y-axis here, you see the 14-day hospitalization rate. On the x-axis here, you see the share of the population that has been fully immunized. When we plot those two values together for our 15 largest counties, you'll see that the counties that have the highest hospitalization rates tend to be the counties that have the lowest vaccination rates. And conversely, the counties that have the highest vaccination rates here tend to be our counties that have the lowest hospitalization rates. Again, I think good evidence to support the effectiveness of vaccines for preventing severe disease outcomes due to COVID-19. We have recently updated our data on trying to estimate the risk difference between vaccinated individuals and unvaccinated individuals when it comes to hospitalization, death, and cases. And we'll be updating this data on our website this week, but wanted to share this preview with all of you, showing that we consistently see a much higher risk of hospitalization associated with individuals that are unvaccinated compared to those that are fully vaccinated. So this figure is showing you the risk difference between the unvaccinated and the vaccinated. And the takeaway here is that vaccinated people are 8.9 times less likely to be hospitalized for COVID-19. So this is just comparing the age-adjusted rate of hospitalization between those two populations. Again, substantial benefit from vaccination in preventing hospitalization. I want to talk a little bit about some of our vaccine effectiveness estimates. So here in the state, we are using our surveillance data to estimate crude vaccine effectiveness. This is not the same type of data that is being used in clinical trials to estimate vaccine effectiveness, but does provide us a rough view of what vaccine effectiveness looks like here in Colorado. So not going to be as precise as what we see coming from clinical trials, but does give us an overall view of what might be happening in the state and how trends have changed over time. So what we've done here is take a look at vaccine effectiveness for different age groups. And we're looking specifically here at vaccine effectiveness against hospitalization and death. And this is for cases that have occurred since July. So we intentionally focus this analysis on the time since July to really account for a time when Delta was the predominant variant circulating here. So this analysis does incorporate any impact that we may have seen specific to Delta. So what you see here is that for our younger age groups, we continue to see very high levels of vaccine effectiveness against hospitalization and death. So 94% range for most age groups here for hospitalization. For deaths, same thing. But when we get to our oldest population, that is where we start to see some clearer evidence of perhaps some evidence of waning immunity. Again, I think emphasizing the clear importance of booster doses. Obviously, most important for our oldest Coloradans, but we're going to talk a little bit more about the importance of booster doses for all age groups over the age of 18 and trying to decrease the level of transmission that's occurring in our overall hospital burden as well. All right, so moving on to some of our modeling data. So this is a figure that is showing you the number of hospital beds that are currently available in the state. And the number right now, based on a 7-day average of available beds, is 759. And then the number of COVID hospitalizations is shown in blue. Yesterday's value was 1,426. And what I want to point out with this orange line in this figure is that we're really at an all-time low for the number of hospital beds that are available in the state currently. You'll see if you look back to our peak last fall, almost this exact same time of year last fall, while we had more hospitalizations at that peak, we had many more beds still available. And there's a variety of factors that are going into this. Probably most notably, as Director Ryan mentioned, that people have gotten back to normal life. So we're seeing higher rates of trauma, we're seeing higher rates of chronic disease and health seeking among individuals right now. So there's much more demand on our hospitals than just COVID at this point. So we also know that we're nearing influenza season and could potentially expect to see some increased demand associated with influenza and other respiratory viruses. All right, so the next figure I'm going to show you is one of those modeling plots that shows you projections for the number of hospitalizations we anticipate potentially seeing in the next couple of months in the state. One of the values that I'm going to talk about is the potential maximum number of hospital beds available right now. And so I want to explain to you how I come to that number, which is roughly 2,000. So the way that we're coming to that number of maximum COVID-19 hospitalizations that we believe our healthcare system can accommodate right now is really by just simply adding this number of beds that are currently available to the number of COVID hospitalizations we have right now. And then assuming, and this is a very, probably improbable assumption, that all of these remaining hospital beds, 759, could be used to take care of COVID-19 patients. So when we add those two numbers up, we get sort of a maximum number of roughly 2,000, maybe up to 2,200 hospital beds that could possibly be available for COVID-19 patients. And so then imagine here in this figure that there is a horizontal line here, that threshold of hospital beds drawn somewhere between 2,000 and 2,200. And then look at these individual curves, and I'll talk you through what each of them mean compared to the maximum threshold that we estimate is possible in the state. So this particular figure is showing you the potential impact that booster doses could have on decreasing the overall hospital demand in the state. I'm specifically looking at peak hospital demand. So right now, I want you to focus on this blue line, which is our observed hospitalization data, and then starting where these lines split, projections of hospitalizations in the state. If you look at the blue line, that is showing you our current trajectory. So if we continue to have individuals receive booster doses at the same rate they're receiving booster doses now, the projection is that we would reach a maximum of 2,258 hospitalizations on January 1st. If we are able to double our booster dose uptake in the state, that potentially can decrease the number of maximum hospitalizations down to 2,156, also brings our peak a little bit sooner on December 24th. And then if we can reach our state goal, which translates to 75% of eligible individuals in the state, and by eligible I mean over the age of 18, receiving a booster dose, you can see that we get down to 2,082 peak hospitalizations on December 20th. And the difference between these numbers is pretty important, given that this 2,000 range is really our bed capacity in the state at this point. And so when looking at strategies to try and preserve our hospital capacity, booster doses emerge as a really important strategy, a way that we can decrease the overall demand on our healthcare system and potentially get us back to a place where we would be much less likely to risk exceeding our hospital capacity. Moving on to the next slide. Next, our modeling team took a look at the potential impact of monoclonal antibody therapy in preserving hospital bed capacity. And we're working on updating projections with uptake of monoclonal therapy in the state. And we're going to hear more about the rollout of monoclonal antibody therapy and the aggressive approach we're taking here in Colorado to ensure access to this life-saving medication. But in general, what we found through the literature and looking at different rates of effectiveness from clinical trials of monoclonal antibodies is that we could expect potentially a 13 to 23% reduction in the overall peak number of hospital beds needed in the state if we were to aggressively roll out monoclonal antibody therapy in the state. And by aggressively rolling that out, I mean 30% of eligible patients receiving monoclonal antibody therapy in one scenario, and then in a higher uptake scenario, 50% of eligible individuals receiving monoclonal antibodies. And this does translate to 200 to 400 fewer hospitalizations at peak. Again, a really important number and another important strategy to try and get us back down to that potential level of hospitalizations that are below our maximum capacity in the state. The final thing I want to say about those modeling projections that I showed to you, as I mentioned at the beginning, this data was refit just yesterday following this really rapid increase in hospitalizations. And that change in shape of the curve is really what has driven up this bed need, this hospitalization number so high to that 2,200 level. It is certainly possible that if we were to see that increase slow, that would decrease the overall projections needed in the state. But at this point, wanted to share this data with you and show you a potential concerning situation developing. All right, so finally wanted to talk about residential healthcare outbreaks in Colorado and comparing 2020 to 2021. So I mentioned at the beginning that we have seen an increase in outbreaks in the state. Keep in mind, outbreaks associated with long-term care facilities are 2 or more cases. But what you'll see here is we have, certainly as the cases have increased in the state, just as we saw last fall, we have seen an increase in the number of outbreaks occurring. But a really important difference between this fall and last fall is the overall size of those outbreaks. And I think it's important to emphasize the difference that we're seeing in the number of cases, the number of hospitalizations, and the number of deaths that we're seeing associated with these long-term care facility outbreaks. So this first figure here on the top is showing you cases associated with long-term care facilities in 2020. The figure along the bottom is showing you cases associated with outbreaks in 2021. And you'll see that there's there's obviously incomplete data from November so far, but if you compare October to October, there's a dramatic difference in the number of outbreak associated cases that we've seen in these facilities. Similarly, if you look at this data for hospitalizations, so again, hospitalizations in 2020 associated with outbreaks in this top row, compared to 2021 outbreak associated hospitalizations, you'll see there's a very distinct difference between the number of hospitalizations that have occurred. And then finally, the number of deaths associated with outbreaks, a very substantial difference in that number for October of last year compared to October of this year. And that was my final slide. Thank you.
Rachel, Steve Pietro, excellent presentation. Thank you very much. Will you be able to share those slides with us?
Jill, is there any reason or others were unable to share the slides?
Yeah, we can share the slides with you.
Good. Thank you very much.
Absolutely. I'm going to ask the rest of the members if you can hold your questions. I know that the governor is on and he's going to talk about some of our strategies to reduce transmission and relieve some of the pressure on the hospital system. So I'm sure the governor would be happy to take a couple questions, and then we can also proceed with our questions for Dr. Herlihy at that time. So Governor, welcome. I'll turn it over to you.
Well, I want to thank the members of the GEERC for your hard work. We all had hoped that we would not be meeting about this pandemic right now, but we still are here. People sometimes ask me, is the pandemic over? I say, with 1,400 people in the hospital, this is not the endemic state of this virus. The pandemic will be over. There will always be people hospitalized by the virus. In some years, they might very well number in the hundreds. But the pandemic is not over with 1,400 people hospitalized, especially with these new projections. I wanted to update you on what the state is doing to get ready and additional steps we're taking to reduce transmission. Before I get into that, I just have two brief pieces of additional commentary on Dr. Herlihy's slide. Could we go to the county and rate correlation slide again? I just wanted to provide, since there's so much tough news, I wanted to sort of share the glasses half full on the correlation of the counties with the hospitalization rates. What you see here, and this is the remarkable one, is that the counties that are around 80% vaccinated, they're at a third to a quarter the hospitalizations of the other counties. Perhaps not truly at the post-pandemic endemic rate of the virus, but we wouldn't be having this anything close to an emergency of hospitalization if other counties had the same vaccination rate as Eagle, Broomfield, and Boulder. You're talking a third to a quarter of the mesas and pueblos and welds. And it really seems like around that 80% vaccination rate. You don't get, and it's probably a misnomer that people ever talked about, that herd immunity, but you get a level of herd resistance where the hospitalizations have a fairly precipitous drop. And if we had a quarter of the hospitalizations in the state today, we wouldn't be in nearly the situation we're in. So I just want to offer a hopeful glimpse of that, that around that 80% mark, we see some hopeful data about the hospitalization side of this crisis. The other slide I wanted to look at is the Crude vaccination efficacy rates. Real briefly again, this should also show the importance of the booster for everybody, because I want to remind everybody that what we're seeing in the 80 plus is potentially two things, right? Yes, a weaker immune response and resistance, but we also need to remember that 70 plus and 80 plus, they were the first vaccinated, so they've been the longest. So we're seeing both of those factors combine, right? Perhaps a different characteristic of an antibody response and resistance among the older Coloradans, but also those are the folks that had it 7, 8, 9, 10 months ago, the very first ones in December now, nearly 11 months ago. So it's a combination of both, and it's certainly possible that we won't continue to see that high level of 94% in the 40 to 59 without that additional dose, because only relatively fewer of that group are coming up on the 6 months. So the booster is critical. You saw the impact on hospitalizations. It will also have an impact on reducing transmission. So I want to go to what we're doing, because obviously probably the most alarming part of the presentation is showing how close we're getting on hospital capacity. And I think it's important that we have not one, not two, but kind of three ways to avoid breaching that. Dr. Herlihy went over two in the model. Increasing boosters can help, monoclonal can help, and that's part of what we'll be talking about as well. But we also need to expand hospital capacity. If we could go to my first slide, please. So these are the steps that we announced about 2 weeks ago that we would have to take if hospitalizations continue to increase. They have all either been taken or are in the process of being taken. That's the horizontal line. So requesting FEMA medical surge teams. There is one on the ground right now at Parkview. There are 2 more being finalized for the state, and we could very well increase that. As you all know, the staffing side of the hospital issue is an even larger one than the space side. Reactivate crisis standards of care. I believe Dr. France will update you on that, but that is also in process, meaning the crisis standards of care have been reactivated for staffing, but they have not yet pulled the trigger on hospital crisis standards of care and some other potential areas that, if the hospitalizations continue to degrade, could also alleviate some of the strain on the hospitals. Temporarily stopping cosmetic surgeries has occurred. The goal there to reroute resources, including medical personnel, to help with the COVID and non-COVID related surge in need. The executive order on patient transfer has occurred, making sure that patients are routed. When we're overall at 92%, there's some hospitals that are at 85% and some that are at 99%. And we want to make sure, of course, working with the system and working with the hospital association, that where we can and where it's not medically necessary for the immediate treatment, the patients are going to where there's room. And then scaling the distribution of monoclonal treatments, we announced that we began that work 2 weeks ago. That continues. That will have along with the boosters, that has an immediate impact on reducing the size of the peak. And it's a matter of working with both providers and individuals to further scale that. We already have now 5 mobile units deployed across Colorado. We've enlisted about 150 monoclonal providers. I'll be talking to many of the major systems today about how they can also scale that up quickly and what the state can do to support them. So what's become clear, though, is while we announced these 2 steps 2 weeks ago and are in various stages of implementing them, it's not going to be enough. We are worried about making sure that monoclonal and boosters, we hope, reduces the size of the peak, but there could still be a gap in the 30 to 45 day period with regard to hospitalization. So next slide. These are the next steps that we're going to be taking and rolling out in the coming days and weeks if hospitalizations continue to increase. One is we've challenged the team to make sure that by the time of that peak, in about 30 to 45 days, we do have 500 additional beds. Now, it's not going to be the same when we built thousands of beds and they were standalone facilities. This is generally working with providers to activate floors that have been closed, to repurpose other areas. It's both the staffing and the space. This has already begun. There's 20 new beds in Parkview, staffed by FEMA. Some of these will be tied into the additional FEMA capacity, some will not. But I've challenged the team to make sure that we have, in 30 days, 300 to 500 new beds for that anticipated peak in case the other interventions are not successful at reducing the size of that peak. We want to make sure that every Coloradan gets care. We also know that we need to make indoor events safer. We can't afford super spreader events. And, large indoor events where everybody's vaccinated, is it possible the virus could spread to a few people there? It is, but it's a very different characteristic of how effective the Delta variant is. It's seeking out and infecting the unvaccinated. If you have a sizable amount of unvaccinated in a super spreader event, it might not be 5 or 10 people, it could be hundreds of people that get the event. That is going into place already. Ball Arena is implementing that. We're looking to work with other cities and venues to for this to play a more significant role in the short to medium term suppressing the virus. Policies like this also make our events safer for everyone, continue to inspire confidence in going out. We're focusing on Denver, largely due to that's where most of the venues are, hospital capacity issues. There have been cities across the country that have already implemented this, to be clear. But we have not had any cities implement this in Colorado. We have had private venues implement this. We know we need to do better. We are going to do better. And we are going to be working on policies that drive more Coloradans to get the life-saving vaccine as well. That is more of a longer term effect, but we know that this kind of policy, for instance, if Ball Arena has it and people really want to go to a game, on the margins, it'll help increase the vaccination rate as well. But it has the immediate benefit of decreasing spread. Boosters, we are going to be, you saw Dr. Francis' announcement yesterday, we're going to be taking an additional step, just to be totally clear. And this one has been a frustrating one for me and members of our team because frankly, we feel that the CDC and the FDA bungled the messaging on the booster. They made it very complicated. The basic message is if it's been 6 months after Moderna or Pfizer, you should get it. If it's been 2 months after J&J, you should get it. The way that we're able to make that official from the state perspective, it's been sort of the unofficial policy of the state from the beginning in terms of not turning anybody down and self-attestation, is we're going to be issuing an executive order soon that really says that Colorado is a high-risk institution and everyone is eligible in Colorado. on the argument that you are part of a high-risk environment by nature of being in Colorado. So it's just another part of the legal framework for making sure, and a communication strategy to make sure everybody knows this is, whether it's a 3-course vaccine like DTaP and others, or whether you call it a booster, this is what we all need to step up and do. We need to hit that 75%. If you got the first, you get the third. And so we're providing yet another framework for that. Because of the very convoluted messaging that's occurring on that federally, we're trying to provide less ambiguity. We also are, I've directed Patty Salazar at DORA to provide additional emergency regulatory relief to the healthcare workforce, meaning how can we tap into retired nurses, out-of-state nurses, temporary expansion of scope of practices where people are qualified to do that, just really working closely without sacrificing quality of care to make sure that we're able to deploy and get the most out of our healthcare workforce. So look for additional steps in that area. And then, of course, importantly, it appeared on the last one and it appeared on this one, expanding use of monoclonal antibody treatments. And so that is both on the consumer education side. This will be the topic of our press conference on Friday, but also on the provider side, the physician side, standalone urgent care facility side. We know that this will have an immediate impact. As you know, it's too late when people present and need hospitalization after the condition has worsened. This is within the first week or so of infection. When you test positive and you're high risk, you're a great candidate for monoclonal. And it ties into testing as well, because if people don't know that they have it, they can't seek out monoclonal until it is too late in some cases, unfortunately, if their health degrades and they develop a secondary impact and or need hospitalization. And after 2 weeks, there are other steroidal treatments, but the highly effective monoclonal treatments that can reduce hospitalizations by 70 to 80% are no longer available. So it ties into the overall focus on testing. And so those are kind of the next steps. Just as I was clear when I announced the last 5, it doesn't mean these are all happening today. Some they're over the next few weeks. But if we see hospitalizations continue to increase, this is the playbook to make sure we don't exceed hospital capacity in that newly projected peak in December. So I just wanted to make sure GEERC, as leaders in the emergency response and pandemic response, we're aware of these steps and happy to have a conversation. And I know Dr. Herlihy just presented. Please ask her or me any questions or provide us any comments or suggestions on this plan.
Thank you, Governor. And if you could put your questions in the chat, it might be a little bit easier to manage. And I know Michelle Barron has a question, so why don't we start off with you, Michelle?
Is anything really going to look different to us right now? I mean, when that happens, or is it just going to? No.
I cannot hear her.
It'll be exactly the same, except you'll just be in a virtual.
Michelle, can you ask your question again? We're having a hard time hearing you.
Sure. Sorry, I'm having trouble with my mute buttons. You'd think I'd be good at this point. I guess I had a question regarding pharmacy standards. And previously you had an executive order related to waiving some of the pharmacy standards that were in place before. And sorry, I don't have it in front of me, but there's significant a number of shortages. The one most crucial right now that's going to affect everyone countrywide is 5 and 10 mil saline flushes, and there's rules around preparation and management of that. And our pharmacy team obviously was very concerned about not having any kind of cover given the current scenario.
Yeah, if you could pass along that, and Dr. France is on the line, when that is the in-process standards of care. So the one that he's activated is staffing for hospitals. Others are under consideration. And if you can provide the backup on that to Dr. France, he's empowered to make that call if and when necessary.
Great, thank you.
Okay, and Darlene Taddy has a question about oral therapy, the antivirals. I know we've just started to get information from the federal government on when that will be available in Colorado. Scott Bookman or Diana, or does anyone on the team have information on that?
I think Amanda Hedinger probably has the best information. Amanda, are you on?
I am, yes. So we had a call last week and this week again, just in some initial planning for that as it pushes forward. Right now, it's looking like the beginning of December for the rollout of that. it too is going to be allocated at the state level. So it'll kind of mirror the process that we have with the monoclonals right now for that ordering and allocation process. But there's definitely more to come on that in the next few weeks. We'll make sure that we get that information out as we get it. Thank you,
We have
Charlie.
not built, to be conservative, we have not built in any benefit from that to our hospital projection model, right? We don't want to take that to the bank, or that's potential upside for sure, but we want to be prepared. And that is an unknown about the exact timing and quantities.
Absolutely.
Dr. Pastula, would you like to ask your question?
Sure. So with all the strategies on the table, and particularly the counties with the most hospital stress, have you all looked with modeling, specifically just temporary targeted localized mask requirements for indoor public spaces? Because that, serves as source control, can cut down on the dose, and could potentially have benefits to preventing any influenza and other respiratory viruses. So Dr. Herlihy, have the modelers looked at just kind of temporary targeted mask requirements in the areas like the hottest spots?
Yeah, so I can answer that question. So we have looked at a variety of scenarios and are actually doing some updated work this week and into next week, looking at additional scenarios, including a variety of strategies around mask use. So yeah, there are a number of analyses that are underway at this point.
There are also several counties in Colorado that have active mask requirements, including Larimer and Boulder.
And Dr. Douglas is asking, is there likely to be sufficient oral antiviral supply to supplant the monoclonal antibodies? And Diana Herrera, I know that you have information about what our original supply is going to look like.
I actually think that's Amanda Hettinger has information about our supply.
Yeah, I think there's a lot still to be learned on that. I don't know that we have numbers specifically for that. I do think the projection is fairly low, unfortunately, but like I said, more to come on that.
I think we think it's going to roll out like everything has rolled out, where there's a limited supply at first, and then of course that picks up. But I think we all know the antivirals could certainly be a game changer in keeping people out of the hospital. Let's see, let's go to Megan Mitchell. And Megan asks, are there other staffing models that have been discussed outside of pulling in extra nurses? Maybe Scott or Mike.
Yeah, I think that we are looking at all possible ways to expand staffing in the state. Obviously, looking at those who've recently left the workforce is a really good way to bring people back in and increase staffing quickly. We are looking at, a lot of facilities are already using models of extenders where they're moving, nurses who don't necessarily specialize into the ICU to work with trained ICU nurses to expand capacity there. And, we'll continue to look at all the ways that we can to bring staffing contracts from out of state into Colorado to expand our capacity.
All right, any other questions? Please put them in the chat. I'll see if I missed any here. How do people get onto the medical surge teams within the state?
If an individual wants to join a team, the easiest way to do that is to sign up with our volunteer mobilizer. And we can provide information on that, but that's the quickest way to come in.
All right, I don't see any more questions. Governor, want to thank you for joining us today.
Well, thank you to the GEERC for, day in and day out working on this. As I said, we all hope that it would no longer be emergency pandemic response at this point, but it still is, of course, and we are not yet in an endemic state of this virus when our hospital capacity is being threatened, and we continue to take extraordinary measures, each of you in your own capacity, together as a GEERC, together as a state, county health departments, to get through the difficult next few weeks and months. Thank you.
Thank you. All right, I did see one late addition question in the chat, and I think either Scott or Mike Willis can answer this. It says, what about plans to offload capacity for patients in hospitals who could discharge but have nowhere to go, either SNF unavailability or placement issues?
Yeah, sure, Jill, I can take that one on. The Unified Coordination Center has begun engaging with facilities that could take those patients and offload them if they just had additional staffing. We've identified several that have capacity, either a wing they can't operate or a floor they can't operate, and are beginning engagement to provide them staffing so that they can then receive step-down patients.
All right, thank you, Director Willis. And with that, I'm going to move us along to our next agenda item just to make sure we're able to get to everything. So let's go to Diana Herrera for a vaccination planning update.
Good morning, everyone. Thanks for having me. Give me 1 second to pull up my slides. Okay, can everyone see my slides okay?
Yes.
Okay, so I wanted to start by talking where we were globally with vaccination rates. So this data is available on our website. And you can see here for kiddos 12 and older. So this is the group that has been eligible for vaccination the longest. We sit at just over 79% for one dose and 72% for fully vaccinated. We have reached 80% of our adults 18 and older that have at least one dose, so that's really great news. But as you know, Dr. Herlihy and Governor Polis were saying, while these rates are really great with the Delta variant circulating, we are seeing more people still be in the hospital, and it really is a pandemic of the unvaccinated. And I'm going to talk a little bit about boosters and our latest iteration of our vaccine campaign, but we still remain heavily focused on trying to get these remaining folks that are not vaccinated to be fully vaccinated so that they have protection. In the coming days, we will be updating this little dashboard on our website to include data on our 5 to 11 population that just became available, eligible last week. In terms of boosters, so we looked in CIS at every single person that was eligible for a booster. And so we, how we determined this was anybody that was 18 and older and that was at least 6 months out from either their Pfizer or Moderna primary series or 2 months out from their J&J. We looked to see who would be eligible for vaccination. And then we started sending out text messages and emails to those folks to encourage them to get that booster. So you can see here, we sit at just over 26% of those folks having received their booster shot already. We do continue to push on encouraging people to get a booster as much as possible, particularly for our older adults that could use that additional protection. This number of eligible Coloradans changes every single day as more folks become 6 months out from their mRNA vaccine or 2 months out from their J&J. They become eligible for that booster. And so this is where we sit here currently at 26%. In terms of protecting residents in our long-term care facilities, this does continue to be a focus for us because there are outbreaks and these are still remain a very vulnerable population. So in terms of residents, overall vaccination for folks in these facilities sits at 94%. and we're at almost 91% for the staff in these facilities. Most recently, we just started tracking in on boosters for both of these populations, and we sit at just under 34% of residents having received a booster and around 12% of staff. This is something that we continue to focus on. We did a round of booster clinics for long-term care facilities. We partnered with a number of pharmacies to get this done, and we are continuing to collect data on the boosters that were administered to this population. But our goal here with these folks is to try and get above 90%, upwards of 92% for the residents, because they do need that extra protection to make sure that they don't get sick. So moving on to the latest iteration of our vaccine campaign. So while we continue to focus on vaccinating the unvaccinated, making boosters broadly available, we have pivoted a little bit to broaden our campaign to include this new age group that just became eligible last week. So Pediatric Pfizer has been approved and has gone through all the regulatory channels at the federal level for use in kiddos 5 to 11 years of age. This vaccine, it's the same vaccine as the Pfizer vaccine, but a smaller amount is administered to this age group. So it's roughly about a third of a dose of the adult dose. This is a 2-dose series separated by 21 days apart, similar to the adult Pfizer vaccine. And the safety data that was reviewed in making this vaccine available was from clinical trial with about 3,000 kiddos that part of them received the pediatric Pfizer vaccine, part of them received a placebo. There were no severe adverse events noted in the clinical trial, and mild to moderate symptoms, very similar to what we saw in clinical trials for adults, including soreness at the injection site, headaches, muscle aches, and fevers. And out of that trial, they determined that the vaccine, the pediatric Pfizer vaccine, was 91% effective at preventing symptomatic COVID. So with this new age group, we have a goal of vaccinating 50% of kiddos in this age group with single dose of COVID vaccine by January 31st. And part of the reason why we chose this particular goal is it took us around 3 months to get 1 dose of the Pfizer vaccine into that 12 to 17-year-old population. So our goal here, again, is to hit 50% of this age group by January 31st. We have about 480,000 kiddos in this age group here in Colorado. So that translates to about 240,000 by the end of January, receiving that first dose. And you can see here, we just started vaccinating this age group just a few days ago, and we are at 2.8% having received their first dose in the past few days. So what are we doing to get this age group vaccinated? So I want to start by saying no wrong door. So while we are doing a lot of promotion and a lot of clinics and events to get this age group vaccinated, we continue to focus in on making sure that anybody that's unvaccinated has opportunity to be vaccinated, as well as anybody that needs a booster to also be able to get that booster. So while we're doing lots and lots of kid-focused events around the state, and I'll talk about those in a little bit, all of those events are going to offer doses, adult doses, Pfizer, Moderna, and J&J at those clinics. So any parent or guardian that is bringing their kiddo in to be vaccinated, and they either are unvaccinated themselves or need a booster, they'll have an opportunity to receive those vaccines at these kid-focused clinics. So lots of focus continuing on provider recruitment and education. Vaccinating a child is not the same thing as vaccinating an adult. So we've done a series of webinars to ensure all of our providers are ready and know all of the things that they need to do to vaccinate this younger age group. And we continue to focus in on recruiting providers to be part of the COVID vaccine program. How we turn this eventually into a routine vaccination program is having, all of our primary cares and other places that people normally get vaccinated part of this program and are able to order doses as they need on an ongoing basis, just like our routine immunization programs. We've got around approaching 1,300 providers enrolled at the state level, another 400 or so enrolled at the federal level. That's primarily our pharmacies that are able to give COVID vaccine right now. And we continue specifically in recruiting and enrolling primary care pediatric providers, so our family physicians or pediatric offices, to ensure that we've got broad coverage for this particular age group. We've also done lots of work in terms of parent and educator communications. We've got lots of toolkits that we've pushed out. We have a media campaign that will be focusing in specifically on parents and answering their questions. We've done televised town halls on 9 News and Univision to just answer everybody's questions and make sure that they have the information they need to make a decision about vaccination for their family. We're also doing another town hall specifically for educators coming up to answer their questions as well. Equity continues to remain one of our focuses in our vaccine campaign. And we have 15 buses that are currently out in the field that are taking vaccines directly to communities and ensuring that they have the access they need. Sorry about that. If you heard a lot of noise in the background, apologies. So equity does continue to be at the forefront. So in addition to our buses and making doses available all around the state via our buses, we've reached back out to all of the organizations that we partnered with in the very early days of rolling out adult doses and working with those equity organizations to offer the same thing, offer them 5 to 11 clinics, offer them booster clinics so that we can reach our BIPOC Coloradans where they are and ensure that everybody has access no matter who they are or where they are in the state. In terms of targeted outreach, we are doing individualized messages to various age groups. We just did a huge push on anybody 18 and older to encourage them to receive their booster dose. We will be doing targeted messages for parents of 5 to 11-year-olds, and then we're going to do another round specifically for our older age group, Coloradans 70 and older, to again, if they're not vaccinated or they need a booster, where can they go to receive those doses? Or if they need help scheduling an appointment for themselves, how can they get that support? And then I'm going to talk a little bit around all of the events and partnerships. Our goal here was really to make sure that at least one clinic in every single county, specifically for this 5 to 11 age group, but it will also offer boosters and first doses at these clinics. We wanted to make sure that there was broad access statewide. And so we've got lots of primary care offices, our local public health agencies. We've got safety net clinics and federally qualified health centers, all administering doses. And then we have worked really to supplement all of those efforts by doing state-run events and clinics where they have been requested. So lots of partnering with schools and school districts and really focusing in on places where kids and families are already going to be. So lots of partnerships with like Boys and Girls Clubs, libraries, museums, zoos, to host events at places where families are already going to be, just to make it as simple as possible and make it a little bit of fun. Some of these places are offering free tickets to people that get vaccinated at their clinics. So, if somebody brings their family there, they can then go and enjoy the museum or the zoo afterwards for free. These are just a handful of the events that we've got coming up. We are working on many more of these and getting them scheduled. But again, really focusing on trying to ensure that there's access statewide and in places where families are already going to be. And that's my last slide. I'm happy to take any questions.
Diana, thank you so much for that presentation. We've got a question for the team from Peter Pons that says, given the waning immunity over time, will repeat boosters be necessary every 6 months or so?
We do not yet know that. It is certainly possible that this might be necessary every 6 months. Turning this more into like flu season, where you have to get your vaccine every single flu season in order to be protected. It certainly could be the case, but we don't yet know that. One of the things I will say is particularly with immunocompromised persons. So there's been that recommendation that immunocompromised people receive an additional dose. So the premise here being those folks didn't mount an adequate immune response when they got their first 2 doses or 1 J&J for their primary series. And so to give them an additional dose as part of their primary series to get their immune levels up to the same that a non-immunocompromised person may have experienced. With those people in particular, it was sort of a quiet recommendation that came from CDC. Those folks, even after they receive their additional dose, there is a recommendation that they go ahead and get a booster 6 months after they've gotten their additional dose. But I haven't seen any official recommendations on boosters every 6 months beyond that.
Okay, and John Douglas asks a question that the team's been wrestling with, I know. It says, assuming unvaxxed 65 plus are highest risk of all, does CDPAG have any age targeted approaches to reach them that the rest of us should be cascading from?
Yeah, so we're just talking about this. We actually are going to be specifically doing some promotion in media markets, particularly around Mesa, El Paso, Pueblo, where we are seeing the highest percentage of older Coloradans either being unvaccinated or not yet having a booster. So we are going to be doing some media efforts in those areas to encourage vaccination. And we're also going to be doing targeted text messages. We'll do this for all 70-year-olds. This isn't going to just be in those areas, but really encouraging that older age group, if they are unvaccinated, if they need a booster, we can help them. We've got a call center with like 100 folks that can take phone calls and help people get scheduled for a clinic.
However,
Okay, then,
sync
go ahead,
up.
John.
This is really however we can sync up would be great, Dana. This is a huge challenge, and this is probably going to make as much difference in terms of the hospital crisis as anything. So,
yep, yes, agree. Luckily, our 65 and older. I didn't have that on my slide. We sit. They are doing a little bit better when compared to just adults 18 and older. Our 65 and older group, around 38% of them have gotten a booster dose so far.
Okay, and then Christy Chowdhury has a question. Given that many healthcare workers were also vaccinated 8 to 10 months ago, do we have any data on waning immunity in that population, which is younger and healthier overall?
Rachel, I don't know if you have this data. We don't have anything specific in our data sets around waning immunity. Do you have anything, maybe any national data?
Yeah, I think we would probably need to look to some national data. I think there are a lot of challenges and complexities in trying to look at data for time since vaccination. There's just a ton of confounders associated with that data. And then we would additionally need to have good data on whether cases were healthcare workers or not. And I think there's a decent amount of incompleteness in that data. So I think we'd have to look at other sources than our data, unfortunately.
I think one of the things that you showed on one of your slides is it at least appears to be it's those older age groups where we might be seeing some waning immunity compared to our younger age groups.
Yeah, certainly any evidence of waning immunity against more severe disease outcomes, at least in our data, appears to be very much limited to older adults. For prevention of infection, we do see broader waning immunity in most age groups, though, and probably a clearer effect of time since vaccination. So like what we could do is look at age-specific data on vaccine effectiveness over time, but trying to get to that piece, and we're working with the university to try and do some modeling and account for changes in Delta variant and other factors that make these time series analyses challenging. But yeah, I think the bottom line is not great data on healthcare workers specifically.
All right, I'm going to move us along to Dr. France. He's going to get a little bit more specific about booster dose and Colorado's specific recommendations. So Dr. France, I'll turn it over to you.
Thanks, Dr. Ryan, and good afternoon, everybody. We are running a little behind, so I'll make this relatively brief with my updates here. As you heard from the governor, he'll be working towards an executive order that will describe our state as an institution with increased risk of exposure and encourage everyone 18 and older to be vaccinated. As we've seen these cases go up over the last couple of months, and we're looking for different levers that might help slow things down, certainly information about waning immunity of our primary series with these vaccines and what it could be contributing to the increases in cases has been on my mind and folks across the country. And now I think it's pretty clear, study after study is showing that 4 to 6 months after completing the primary series, vaccine efficacy against infection declines. I think it's really important to describe and distinguish vaccine efficacy against severe disease and hospitalizations versus vaccine efficacy against infection with potential transmission. And as Dr. Herlihy has shown, if you are unvaccinated, your risk is 9-fold for being hospitalized than if you are vaccinated. And in general, it appears that vaccine efficacy remains strong for people under 60 against hospitalization. At the same time, it's clear that vaccine efficacy declines over time with the 2-dose or 1-dose of J&J. A study, I think last week, of over 780,000 US veterans found vaccine efficacy for infection at 88% in March had dropped down to 48%. I believe it was September or October. A study in Southern California, Kaiser Permanente, showed declines. And so many of these studies seem to show that a vaccinated person may still get ill, though they are protected from hospitalization. And so it's been our mind that vaccinated persons becoming ill may contribute to the ongoing cases that we have. And we know that in general, 1/3 of the cases we see each week now are among persons who are vaccinated. Not surprising given high rates of vaccination, but these persons who are vaccinated and now infected can be transmitting, and their transmissions may go to the unvaccinated, who then are at risk of becoming hospitalized. So with that in mind, and thinking about how we might slow things down, it seemed that we should consider a broader vaccination with boosters. We know that in Israel, they saw return of cases in June and decided by the end of June to do these age cohort boosters. And what I found particularly interesting was that a few weeks after they vaccinated the 60-year-olds, the cases and the transmission among 60-year-olds started to decline, while the cases continued to rise for the rest of the population. When they moved on to the 50-year-olds, they started to decline while the rest of the population increased. And so it certainly demonstrated a pattern that suggested that broad booster efforts can potentially reduce transmission and cases in the subsequent weeks. Knowing that our hospitals were at high risk of being overwhelmed by COVID cases at this time and in the upcoming weeks, it seems like it's an important potential strategy to encourage anyone over 18 who is now due for their booster to receive it. And I would say that too, I checked this out with the CDC, who who understood our interpretation that we can consider the state of Colorado an institution at which there's increased risk for exposure, and heard a couple weeks ago from the FDA that they would be considering whether or not boosters for all is appropriate. That seems to tie in with what we just saw announced yesterday, which is that Pfizer has asked the FDA to consider recommending boosters for everyone over age 18. If I had to predict, it would be that with rising cases in the United States, very likely other places like Colorado, which we might consider hot spots, will consider a broader booster recommendation as a way of potentially controlling spread, if not hospitalization. So that's what I wanted to share with you today around the boosters. A couple of other updates, if you don't mind, while I have the floor. The first, of course, is, as you heard in the news, I reactivated the crisis standard of care around staffing yesterday. This after consultation with healthcare systems across the state and hearing the stress of our workforce. As you know, this crisis standard of care on staffing provides a framework for hospitals to think about how do they extend the staff they use and how do they provide acknowledgement of the hard work of the staff in these trying times, forgiving the staff if they aren't necessarily keeping up with a recertification program, or if they have to take care of more patients than they might have otherwise. Understanding that these are stressful times, honoring by reactivating this crisis standard of care, I think was important. And you probably know that this is not a reactivation of the hospital crisis standard of care, which specifically deals with questions of scarce resource and triaging of care. The review that Dr. Cantrell, Dr. Mehta, and others, including myself, have done on the hospital crisis standards of care suggests that it needs some refreshing, that this idea of how do we triage scarce resource is broader than the question of a ventilator or an ICU bed. It may be actually at the combined hospital transfer center where they're having to make triage decisions on how they move patients. It may be something in the emergency room with people coming in and not having enough beds requiring triage. It may be about the use of a scarce resource like a dialysis nurse and not having enough dialysis nurses. And so I've asked Dr. Cantrell, Dr. Mehta, and others to come together again and make some changes, revisions, and proposals for that crisis standard of care on medical care in hospitals. We're meeting tomorrow, and Dr. Cantrell will be chairing that meeting. And of course, the changes that occur with this input will come back to you, the GEERC, to again review, discuss, make changes, and ultimately authorize these changes so that I then may activate them if need be in the coming weeks. We don't have any plans today about activating on them, but it is the time for us to review them and make revisions. Maybe I'll just check in with Dr. Cantrell real quick, if you don't mind, to see if you have any comments you'd like to make on that work.
No, thank you, Eric. No, that I think encapsulates exactly the direction we need to go. And Dr. Mehta has actually put together a draft that we'll be discussing tomorrow, which I think will move us down the path.
Perfect, thank you. So I'll pause here for any questions from GEERC members about the rationale around boosters, the activation of the crisis standards of care for staffing, or our work around hospital crisis standards of care.
Dr. Douglas, do you want to ask your question?
Yeah, sure. Eric, maybe you said this, but I hadn't thought of this before. Might states, we weren't #1 in the country in March, but we were maybe top 15, top 20, and might states that actually got going faster be paying a price now? I mean, not so much in terms of do we need boosters. You and I interacted last week, and I support the position Colorado's moving forward in. But I am wondering if that could be part of the explanation of why now, why so bad kind of thing.
Yeah, I wonder that as well, especially when you look at the slow incremental increases in cases over the, is that kind of a reflection of the adoption of the vaccines in the late winter, early spring, and as more people get 6, 7, 8 months out, the cases start to come up? I'm not sure quite how we tease that all out in the grand scheme of things. I think, you know, the other piece of it is that, again, if 20% of people haven't even been vaccinated, that's well over 1 million folks who are available for infection. And the waning immunity combined with a high proportion of folks unvaccinated might come together to explain the experience that we've been having to date. In another scenario, there may be very, very low rates of the unvaccinated, and waning immunity may not necessarily translate to a lot of transmission or growth, because there's just not much exposure happening among the vaccinated with waning immunity. So it could be this unique blend of a proportionally high number of unvaccinated with waning immunity that gives us our experience today.
Thank you.
Okay, and Ivani Soni asks, will we see a recommendation for workplaces that required vaccination for employees also require boosters at this time?
Yeah, that's a good question. And I would say 3 weeks ago when we were first talking about this new recommendation for boosters in these special groups, of course, the ACIP was clear there were some groups who should get it and there were other groups who may get it. And at that time, you know, requiring a booster as part of the general workforce mandate, when ACIP said it was a may recommendation rather than a should, felt like we were stretching beyond personal decision making, which was implied with the may recommendation. I'm not necessarily comfortable to require the booster as a should recommendation for everyone over 18 at this point. I do think it will be likely that there could be a boosters should be given to everybody over 18. And I think when that happens, then the employment mandates should reflect that requirement as well. It's essentially saying that this isn't a 2-dose series, it's a 3-dose series shot. And Dr. Peter Pan asked earlier, are we going to have to get one every 6 months? And I felt like saying, ask me again in 6 months, because I think, you know, by then we'll have maybe the data from Israel where they've done all their vaccinations in July and August and September. Are they going to see a bunch of breakthrough cases next April and May? Or will they find that there's long-lasting protection from a 3-dose series?
Okay, thank you. And Dan Pastula, I'm going to give you the last word. You've got a question. I can't tell if it's for CDPHE or for the GEERC in general, so I'll let you ask it.
I think this is for everyone, and Dr. France, feel free to take the first shot with this, but what can we do to support our healthcare providers and staff while we're relaxing these staffing ratios? And given just the high volumes, there's already a lot of burnout and PTSD among healthcare providers and staff just kind of going through all this, and then particularly in the last few weeks to months, and kind of, I understand the need to relax the staffing ratios, but I think that's going to add stress on top of it. So what can we do as a GEERC? What can we do as a state? What can we do as CDPHE to help support them through this, the people on the front lines?
Yeah, and of course, the obvious answer, of course, is to do all those things that prevent yourself from catching COVID. And we know what those are: vaccinating the unvaccinated, boosters for the people 60 and older in particular, because we know they are more at risk for being hospitalized, and then boosters for the under 60 to reduce potential community transmissions. And then the question is, well, what can we do to reduce the burden of hospitalization right now? And each of us make individual decisions about the things we do that put us at risk for hospitalization. And maybe we pause for the next 3 months on something that might be particularly risky. That's more of that individual decisions about how we live our lives every day and what risks we might put ourselves into. I don't know if others have thoughts. I'd love to hear them.
You know, Dan, it seems like I'm assuming the frontline workers in the hospital, directors of nursing and facilities like the one you work at, might have some of the immediate best ideas, because stereotypically assuming nurses are getting hit the hardest. And
I can also read Megan Mitchell's comment. She says, I would suggest stop asking the nurses to keep doing everything. Allow all of our professions to function at the top of their profession, not limited by facility preference, and engage the frontline staff in the decision-making processes. So good food for thought. Thank you. I'm going to move us on to our next topic. Amanda Hedinger is going to talk about monoclonal antibody therapy and how we are distributing this far and wide and really trying to promote it for folks that do catch COVID. This is sort of a precursor to have the antiviral pill, which I know we all very much anticipate. But at this time, we both want to get the word out to people that get a positive test result that they may be eligible, and we're trying to make it easily accessible and free. So Amanda, I'll turn it over to you.
Thank you, Director Ryan. I appreciate it. Let me share my screen here really quickly. All right. Can you still hear me? It looks like I may have frozen my screen.
We can still hear you.
Okay, thank you. There we go. It's just a little slow. All right, so just going to go over a few quick topics here. Our current efforts, the efforts that Governor Polis mentioned that are in process, and then just a little bit about reporting, both at the federal level and then here at the state level as well. So current efforts, as you all are aware at this point, back in September, HHS turned the ordering process over to us at the state level. So we are, working each week to make sure that there's equitable and even distribution, making sure that we can order all of our allocation or as much of it as possible, as well as making sure that, the currently enrolled providers have our support in getting those orders placed, and then working with HHS and AmerisourceBergen to make sure that the process is as smooth as possible. It's a little bumpy at times, but it's been working itself out over the last few weeks and getting a little bit smoother. As Governor Polis also mentioned, we do have the 5 buses available currently. We are on week 2 of that deployment. So you can see here in the bottom right of the screen, I know it's a little small, but those are our numbers from that initial rollout of 3 buses from last week. We're up to 5 buses now for this week. But you could see over the course of the week and us getting that message out that those appointment numbers kind of started to increase over the week. So we had a total of 145 referrals from the 3 different areas that they were in. We were able to book 82 appointments, and of those 82 appointments, 73 doses were given on those buses. So it's exciting to know that moving from 5 buses to 10 buses as we move forward, we'll just continue to increase that access in those areas. And we'll continue to roll those out. So we currently have buses this week in Mesa County, El Paso County, Pueblo, Montezuma, and then Weld County as well. We're also doing additional provider outreach each week, really focusing on providers that are able to open it up widely, as opposed to the providers like the IV bars and stuff like that have very restricted access to the general population. Working to communicate with our emergency departments as well as urgent cares to provide access to their current patients and new patients that may be COVID positive in those facilities currently. All right, so just wanted to highlight, these are our currently enrolled providers throughout the state. There are 171 this week. And we have that broken down a little bit to hospitals and pharmacies, long-term care facilities in the green, and then the non-hospital facilities, which are, family practice physicians or the IV bars, stuff like that, that is not a hospital setting or a congregate living facility. And so this is a further breakdown. This was from last week from our numbers of those types of facilities broken down by region. So as you can see, North Central is still the highest. So we're definitely outreaching to more rural areas to make sure that we can increase access in those areas as we move forward. All right, so as we move forward, we've got some big projects ahead of us that we're currently working on. So we're working on a 4-tiered approach, which first tier that includes that outreach to urgent cares and ERs to make sure that we can, grab those people that are already in those facilities and make sure that they're getting treatment once they get a positive COVID test, or once that has been identified, they're not turned away to go find care on their own for monoclonals. We're also standing up some static sites, 3 of them throughout the state with HHS support. And then we're also, as a piggyback to that, looking to increase staffing support in facilities that are currently providing monoclonals or having difficulty standing up monoclonal sites in their facilities because of staffing shortages. So working on that as well. And then, increasing those 5 buses to 10 buses on that mobile capability. And then we're also developing rapid deployment teams. Those teams are going to focus on the congregate care living facilities, such as Department of Corrections, community jails, long-term care facilities, and other congregate housing situations that are identified as outbreaks in outbreak status. So just kind of talk about each of those a little bit more as we move forward. So specifically for those static sites, we are looking at Loveland, Mesa County, and Pueblo for those. Those will have HHS supported staffing. Once the request for those is submitted, we're looking at 10 days to stand up those facilities. So we're still a little ways out on those, but they're coming soon. The conversations are happening quickly. And we're making headway every day on that. So those will be coming very shortly. With that capacity, we also have a spoke and hub capability with that. So if an outbreak is identified within 50 miles of that static facility and we don't have another mobile capability to get out, we can deploy from those 3 locations. So within 50 miles, so giving us a bit more coverage in the mobile capacity as well. Oh, and then I'm going to back up here just a second and kind of talk a bit more if I can. Oh, it's not going to let me back up. But as far as the buses, right now we're finding that really keeping them on site for as long as possible is really best. So initially we had hoped that they'd be more mobile and agile like the vaccine buses, and they can go from location to location on a daily basis or after a couple of days. But we're really finding that in these first 2 weeks that, the longer the buses can stay on site, the better the access to that bus and to the monoclonals is. So we're looking with those buses being able to leave them on site for 2 weeks and then rotating out from there. And then kind of offsetting the rotation schedule. So buses 1 through 5 will be in a site for day 1 through day 14. On day 7, buses 6 through 10 can move to a new location. So then that way we currently have buses moving, or will concurrently have buses moving on a weekly basis to new locations. And then those deployment teams for that rapid deployment will, like I said, those will be up and running by Friday. We'll have mobile capability at that point to get into those congregate care facilities. I think the challenge that we're having right now specifically with allocation is the reporting. So HHS has a requirement for us to report all used doses through their reporting system. And I know it's, again, small, but as you can see on that bottom graph, only about 55% of our current enrolled providers are actually reporting that information up to HHS. I will say that did increase this week. We're up to closer to 60%. But as you can see on the larger upper chart here, total number of doses reported as used were only 984 with an estimated almost 3,000 doses on hand. So because of that lack of reporting, our allocation was down a bit this week. We're down about 500 doses from our previous allocation. So HHS is keeping a close eye on that, and that is going to impact us as we continue to move forward. So really another targeted outreach to our current providers is on its way, and hopefully that will emphasize the importance of them reporting that through their system. And so I know it was a brief, quick overview, but I'll open it up for questions if anyone has questions from me.
I might just quickly add that the hard work that Amanda and her team are doing to build more seats and places is of course being complemented by the strong partnerships with our health systems who are of course offering these in their sites. And I don't think the state will be able to build all the resource to provide all these treatments and therapies, and it's the growing partnership and expansion of use in urgent care centers and outpatient facilities that are associated with our hospital systems that will ultimately get us using as many doses as we can. And sometimes when we talk about what we're doing, it could be interpreted like somehow this is all owned by the state, but that's absolutely not the case here. It's a strong partnership and is owned by traditional healthcare systems as much as it is our work to try and expand on that.
Vani, do you want to ask your question?
Hi, just wondering if you have some resources that we can provide our community pharmacy partners so that they can educate patients who might be candidates for monoclonal antibody treatments. I've just heard so many stories about people don't find out about it till way later on and they don't know where to tell people to go for resources.
Yeah, for sure. So we are currently working on our outreach toolkit. So as soon as that's available, we'll make sure that that gets pushed out. We're also working with the state-supported testing centers to make sure that they're passing out that information to the individuals that go through there as well, so that they have access to that information as well.
Okay, I don't see any other questions in the chat. So thank you, Amanda. Turn it over to Scott Bookman, our last presenter, to talk about hospital capacity.
Thank you, Director Ryan. And I think we've covered a lot of this over the course of this conversation today, so I'll keep it relatively brief. You know, when we talk about hospital capacity, we really look at it from three different areas, right? What can we do to keep people out? What can we then do to increase the capacity so that people who do need to come into the hospital have those spaces available? And then what can we do to ensure that throughput is maximized through a discharge process? And so obviously our efforts to keep people out of the hospital continue to be focused on access to boosters, as we've discussed, and then really increasing that uptake in monoclonal antibodies to those who need it the most. I think our teams have discussed boosters and monoclonals today, and so I won't spend any more time on that. When we start talking about increasing the actual capacity of our hospitals, I think there are a couple of different strategies that we look at. One of them is to make sure that we're using every bed in the state and really looking at all of our acute care hospitals as part of one large healthcare system and not individual facilities. So in partnership with Colorado Hospital Association, the large health systems and CDPHE have developed the Combined Hospital Transfer Center. That transfer center has moved to level 3, which is its highest level of activation, and really looking at every available bed in the state. Because while certain areas may have capacity challenges, we do know that there are more than 700 hospital beds available in our state, and we need to make sure that we are getting the right patient to the right bed at the right time. So that transfer center did move to level 3, and they are working on level loading across the state. Additionally, we are looking at ways to open up more beds in our hospitals. We can do that with our staffing contracts. Director Mike Willis from the state EOC is on. He is, leading our efforts at the Staffing Shortage Fusion Center, looking at ways that we can provide our hospitals with increased staff to open up more beds. And as the governor indicated, we have set a goal of adding about 500 beds to our healthcare system. That's going to be a big lift. We're moving as rapidly as we can, but that will require an enormous amount of these staffing contracts coming in. Additionally, we are still working with our federal partners to request additional federal medical teams. We know that over the course of this pandemic, waves have hit different states at different times, and those federal medical teams have moved around the country to provide staffing support. So we are in conversations with FEMA and HHS to increase access to those teams, like that first team that has arrived on the ground in Parkview. And then finally, our efforts to improve throughput are based on the fact that we know that, in normal times, there are difficulties in sometimes discharging patients from the hospital into long-term care facilities. And so, like every other industry, really in the country at this point, our long-term care facilities, the healthcare workers, suffering from burnout, they're suffering from staffing shortages. And so we, through that Staffing Shortage Fusion Center, are working really hard to do two things. One is simply to provide individual staffing assistance, either through the National Guard or through our contracts, to make sure that we're doing all that we can to keep existing beds open. But we also know that occupancy rates in these facilities have gone down, staffing rates have gone down, and there are skilled nursing facilities, assisted living facilities across the state that have wings or individual beds that are available. They just haven't been staffing them. And so we are working with the providers of all of these facilities, the operators of all of these facilities, to see if we can partner with them to open things up. Rather than creating these freestanding alternate care sites where we have to create all of the systems and all of the wraparound services, we really want to capitalize upon the infrastructure that exists, use the statewide coordination and staffing agencies that we can bring in to increase capacity in these facilities. So in a nutshell, doing our best to keep people out of the hospital with boosters and monoclonals, increase capacity in our hospitals by using every bed and doing all that we can to increase opening up new beds, and then finally ensuring that we maximize throughput as well. So I will turn it over to you, Director Ryan, pending any questions.
All right, questions or comments for Incident Commander Bookman? Give people just a minute to type. And we really do want to thank you. If you work in one of these healthcare settings, we know how hard your life has been for the last 18 plus months. So thank you so much for what you do for the people of Colorado. I don't see any comments or questions. So Eric, why don't I turn it over to you?
Thanks, Director Ryan. It's always important that while we're presenting through many of these meetings, that we take a few.
Scott, I think you hit some of the nail on the head. What I'm seeing when I'm on service sometimes is the slow discharge process to people who are stable or trying to do that, where we're trying to bring people in. So I do appreciate addressing the back end, the discharges, and then the long-term care facility and skilled nursing facility and acute, rehabilitation. I think that, from at least my observation, and other providers can please chime in, that's actually been kind of a bit of a bottleneck that's causing the increase in our hospital.
Thanks, Dan. Scott, is there anything you want to say about that work?
No, I don't think I really have anything to add to that, Dr. France. I think Dr. Pastillo, we've heard the cry from our hospitals. We know that this is a challenge, and it is multifactorial, as everything else in COVID is, and so we're going to work it.
Yeah. Thanks, Scott. Any other questions or comments? Not seeing anything in the chat either, and not hearing anything. Going once, going twice. I will turn this back to Dr. Ryan to final comments and adjourning of our meeting today. Thank you. Let us know if there's any issues.
I'll just in closing, thank you again for your service to the GEERC. And, we're just in a really unique time, and I'm hopeful that, all of you play such important roles in your daily lives that the information we have provided today helps sort of get us all on the same page as to at least the state's response and how we're viewing this. So just want to invite you, to reach out at any point, and let's keep the two-way lines of communication going on this. As Dr. France said, we'll probably need to pull the GEERC back around updating those crisis standards of care, and that may indeed be before our next meeting. So if that's the case, look for an invite there. And otherwise, I'll adjourn the meeting at 12:45. Thanks, everybody.